Okay, so we were talking about management for anxiety. So, we talked about some different classes of drugs we can use to manage anxiety. What's the kind of the mainstay for like kind of chronic maintenance sort of therapy? SSRIs, what else could we use? SNRIs are good. What else could I use? TCAs could be used potentially. What else? Not usually MAOIs. I haven't seen that done too free. I mean, theoretically you could potentially, but typically you don't have to resort to that for anxiety. What else? Wellbutrin could be used. Yeah. What else? So beta blockers wouldn't be good necessarily for like long-term like maintenance of it. It's better for that like performance sort of intermittent use sort of thing there. Anything else? Benzos are going to be better for like acute management, so kind of similar to the beta blockers. But again, with beta blockers, what's the benefit of that over using like a benzodiazepine? Yeah, the sedation, like the mental fogginess, whatnot. Again, if I was, to have to come in, if I got nervous before a lecture, I'd rather do a beta blocker than a benzo because I need to be able to keep my mental faculties about me. Um, but remember, there's a buspirone drug, right? Buspar could also be used as well for kind of chronic management of that anxiety. So that's another alternative, which it's some use out there. But again, think about, what the setting is. If you have an acute sort of bout of anxiety, like, benzo's pretty good for that. Why are SSRIs not good for like an acute anxiety attack? Take too long. They take weeks to kick in, right? So it's not really going to be good from that standpoint. Typically you can start out if you wanted to give a patient maybe like a short course of like benzos just to kind of keep on hand while their SSRIs are starting to kick in. That could be a possibility as well. They can just maintain like a PRN prescription, just for those kind of breakthrough bouts of anxiety. That's totally fine. But typically start off an SSRI, SNRI. Either one of those are going to be great. Not really having any urgent symptoms, and you can just start them off on the SSRI, and that's totally fine as well. Again, typically start off with those two, and as a backup, if the SSRI was not working, then you can use something like a TCA. But again, TCAs are less preferable because it's cholinergic side effects, sedation, etc. Right? So then kind of a host of things that makes them a little less preferable. Good deal. So that's it for the anxiety. Moving in, any questions on that? All right, moving on. Next, we're going to talk about attention deficit hyperactivity disorder. And anyone know what we use to treat this? Speed, right? We're giving some amphetamines. It doesn't seems kind of counterintuitive, right? It seems like we're going to give you a stimulant when you're overstimulated to make you sit still and pay attention, right? It seems a little weird, but it works. When you're dealing with patients with ADHD, it's important to kind of set goals, whether they be children or adults, as the case may be. I think we're starting to get a lot more adults who are not being treated for ADHD. But think about, do you just want them to be able to sit down and like be able to concentrate on a 2-hour lecture, right? That's probably a lot to ask for most people. Like 20 minutes is probably a little bit more reasonable. But you want them to complete their homework, etc., right? Obviously, non-pharmacologic therapy is going to be very helpful. It's always beneficial to start out with that. And again, try to figure out what are the goals, especially between if they're at home versus if they're in school, etc. That can be really important. But when you need medication, stimulants are going to be our first line drugs here. So mainly amphetamines are going to be the first line drugs we're going to be using for these patients. So you already mentioned a few like Adderall. What are some other ones? Vyvanse is a decent one. What else? Like Ritalin, Concerta. There's a lot of different brand names we'll kind of go over. But in general, they're all going to be amphetamines, right? And so how do those actually work? Well, there's a couple different things they're doing. One of which is they're blocking the activity of monoamine oxidase. So we already know what that's going to do for us. What will that do? Increases levels of catecholamines like dopamine, norepinephrine, so it's going to increase levels of those neurotransmitters. They're also going to block the reuptake of things like dopamine and norepinephrine, and then the amphetamines themselves are actually going to be increasing the catecholamine release. So it's kind of several mechanisms they're going to be doing to increase norepinephrine levels and namely dopamine levels. And again, when we're causing those dopamine levels to go up, what are we going to be potentially running into? We like dopamine, right? So dopamine squirts, we like that reward pathway. Lead to addiction. Absolutely right. So again, these can be habit formed. They can be these can develop into addiction for some patients, right? So certainly there's going to be some physical dependence that can develop from this, but addiction is also a strong possibility. And so again, we're going to talk about controlled substances a little bit here. And you guys are familiar with the scheduling for controlled substances? Have I mentioned that before? So what are the different schedules? There's class 1, schedule 1, 2, 3, 4, 5. It's just that straightforward, right? So what does the class 1 mean? There's no accepted medical use, right? So, and what's the other component of that? high risk for abuse potential, right? High risk of developing addiction to those medications. So anyone know an example of a Schedule I substance? Heroin is a good example. Heroin is a Schedule I substance. There is no acceptable medical use according to the who sets this? The DEA, like the federal government. So again, there's always federal scheduling, but also states have their own schedules too. So just kind of keep that in mind. So again, you may have a drug that is a certain schedule here at the Florida level, that it may not be a certain schedule up at the national level. So something to consider. But heroin is a good one because it has no acceptable medical use. However, it is highly addictive, right? What's an example of like a Schedule II? Cocaine is actually a Schedule II. A lot of people probably mentioned that to you before, but that's kind of a misnomer. People think it's a Schedule I, but actually does have some use as an anesthetic, and sometimes you'll see it used for some ENT procedures. Yeah, that's a Schedule II. There's an acceptable medical use for it. Again, you're going to find these amphetamines have an acceptable medical use for them. However, they do have a high amount of abuse potential. We talked about the benzodiazepines for anxiety. Anyone know what schedule those are? It's actually a Schedule IV, which means it does have an acceptable medical use, but has a relatively low abuse potential as compared to something like an amphetamine or something like oxycodone, right? And again, is there any like mystical, or I guess any like hardcore, like concrete science that says this is absolutely a Schedule I versus II versus III? No, it's whatever we decided to be, right? So, for a while, hydrocodone was a Schedule III substance. And then they decided that, okay, let's go ahead and make it a Schedule II because the abuse potential for it was so high, there's so much addiction to this medication, we're going to make it more restricted. And so what you're going to find is that the restrictions are going to be much higher for a C2 medication versus 3, 4s, and 5s, okay? Anyone know what those restrictions are going to be? Talked about them before. Yeah, so C2s always have to be on their own separate prescription. Good, what else? 90 days max with no refills, right? So again, a lot of times for these amphetamines, what providers will do is they'll actually write 3 separate scripts a month at a time. And again, once the patient's kind of already stable on a particular dose and a particular drug, and then they'll say, do not fill until this date, right? So they'll kind of post date it by, several months. So one they'll fill today, one they'll fill in a month. They'll say, do not fill until this date, and then the third one, the final date. Yes, ma'am. Yeah, so typically for any of the controlled substances, you're going to find they're only good for 6 months after that date. But typically, as a pharmacist, if you came and brought me like a script for Adderall that was like 3 months old and you hadn't brought, I'd be a little wary of that one. So there's a high amount of scrutiny seen with a lot of the C2s there. But you're right, yeah, usually there's like a 6-month expiration date on those. How about for like a normal prescription? It's a year, right? It's a year for those prescriptions. Good. Yeah, so just keep in mind there's a lot of scrutiny with those with the C2s. Again, they have to be on paper. They have to be brought in by the patient. They can't be faxed over, and they can't be sent electronically. So again, the high amount of scrutiny with those because of the risk for addiction and all this and diversion, all this is very high. Yes, ma'am.
Some of the Schedule IIs actually starting this summer can be sent by electronic.
Mm-hmm. Yeah, so it's probably like some very specific like software you're having to use for all of that. So that's a new update. But traditionally, you're right, they have not been able to be sent electronically. But thank you for that. Yeah, I'll probably include that for next year. So there you go. Good. So anyway, right, so one of the things you're going to find is that just because one patient does not respond well to one particular type of amphetamine does not mean they're not going to respond to a different variety within that same class. So for instance, there's one called dexmethylphenidate. If they fail that, doesn't mean they're going to fail necessarily dextroamphetamine. So some patients, there's some interpatient variability there. Typically, we're going to be focusing on using extended release preparations. What's the benefit of that, do you think? Could be, so maybe you'll have a little bit of a gentler sort of decrease in levels over time. That could be one thing. What else? Not necessarily that so much, but think about who do you traditionally think about being on ADHD medications? Maybe people are forgetful. Okay, maybe they forget to take their medications. Kids, right? Where do kids go? So they go to school, right? Do you want your kids to be carrying a bunch of amphetamines in their pocket? No, they'd have to go to the school nurse. They have to be pulled out of class. Go to the nurse to get the drug. Give them extended release preparation. Take them in the morning. They're good all the way throughout the school day, right? So, right, there's a variety of reasons, but that is one of the main things you think about is using that extended release preparation for that purposes. Now, is there any way to break that extended release preparation? Crush it up. Yeah, so that's been a potential problem with amphetamines for a long time too. So people would crush them up and then snort the dose, or they can ingest it orally, but they break that and they get the full dose all at one time, right? So again, that's another way that people can abuse it for its kind of euphoric sort of purposes, that dopamine pathway that they're looking for there. But anywho, so here's a couple of different varieties you're going to run into. Methylphenidate, notice there's a lot of different brand names that are associated with these. So just because, don't take it for granted here, oh, I'm on Ritalin, like what drug that is. Go ahead and double check to make sure, because a lot of people say, oh, it's Adderall. And it may not actually be Adderall. They kind of use it as a blanket term for a lot of these drugs. For instance, like Quilivant. I was not familiar with Quilivant until I was working in the outpatient pharmacy at Nemours, and it's a particular form of methylphenidate. It comes as a liquid, right? Because liquids are good for kids, right? Because they can't swallow tablets yet. There's patches that are available that allows for kind of long-acting medication throughout the day. There's dexmethylphenidate. What do you think the relationship is there? Yeah, it's one of the enantiomers, right? It's the right-handed form, the dextro form of methylphenidate. There's what we call the mixed amphetamine salts. That's usually what we refer to as Adderall, so it's going to include amphetamine and also dextroamphetamine. And then there's lisdexamphetamine. That one's actually a prodrug. Anyone remember what a prodrug is? It has to be metabolized first to get to the active form. And actually, one of the things that lisdexamphetamine or Vyvanse was actually kind of touted for was that it was a prodrug. So if I were to say crush up and snort that dose of Vyvanse, you would actually find that a lot of it's not active yet. It has to go through the liver, so you kind of bypass the effect. They try to snort it, you wouldn't really get any actual benefit out of it before it actually went to the liver and had to get a normal metabolism. So that was kind of an abuse deterrent for a while, but then a lot of people actually like the way the Vyvanse works pretty well, so a lot of people actually use that as a very popular one that I see nowadays. All of these are going to be Schedule II substances, right? So again, they're going to have the high amount of scrutiny associated with those. A lot of paperwork, it's a really big hassle. So usually you're just going to be writing for a month at a time until the patient's kind of on a stable dose and you know what drug is going to be best for them. So it's a really big hassle because, again, parents are going to have to bring them back every single month, or a patient has to go back every month to get a new script, and so it can be a bit of a hassle from that standpoint. So adverse effect, what do you expect to see? Well, things like reduced weight and appetite, right? So you're going to find that typically when you have these stimulants on board, they act as appetite suppressants anyway, and so they may not be eating as much. You're going to see weight loss go down, which can be a problem in children, right, who need to be actively growing, need to be getting their calories in. You can also see things like insomnia, headache. If they have hypertension, that's going to be worsened by this. Tachycardia is a common thing there. And just be aware that there's a black box warning on these. One for the dependence issue, right? So you will develop physical dependence on this over time, which could potentially lead to addiction. And then there's also these issues of psychotic episodes and hallucinations that can occur here, right? Because again, they're still amphetamines, just like anyone, bless you, anyone taking methamphetamine, which is a Schedule I substance, can have some of these issues of hallucinations and whatnot. This so can happen with the normal amphetamines. Now, what's an important thing? Say, for instance, you had a patient who is, say, they were 16 years old, they've been on Vyvanse for a good long period of time, and they were about to go get a job for the summer. What's something you should warn the patient about? Drug testing, absolutely, right? So again, on a lot of federally mandated or normal sort of workplace drug testing, amphetamines are one of the core things that they test for, and certainly these patients are going to be positive for that. So you want to let them know, because one, they come back. How would you feel if you had a positive drug screen? You came back. Be a little freaked out, right? They called you up, like, hey, you came back positive. You're like, oh, what'd I do? But let them know that, hey, I have a prescription for this. You supply the documentation. They usually go from there. So just be aware of that. And make sure you kind of educate patients, so that way they don't get too freaked out and they kind of know what to expect. Anyone know what else comes up on those normal workplace drug screens? Well, poppy seeds could show up as. Yeah, it's opioids, basically, right? You have to take a whole lot of poppy seeds, but it could potentially. What other kind of drugs do they test for? Sudafed show up? Yeah, Sudafed actually shows up as amphetamine, so it'll actually cross-react with that for sure. Anyone familiar with Breaking Bad? Not too old for that show, right? Or you guys aren't too young for that show. They use pseudoephedrine to be a precursor for amphetamines, for sure. What other things they test for? What are some common things people get popped for? They worry about getting tested for before they go get a job. Marijuana, THC absolutely shows up on there, right? So they look for opioids, they look for amphetamines, they look for THC, they look for benzos. Benzos also show up on there commonly. PCP is another one that will be on there frequently. What else is on there? Sometimes nicotine, not too common. Cocaine is definitely on there. Cocaine will definitely show up on the drug screen, right? So it's good to be familiar with those normal things that come up there, because again, if you had a patient who's on medical marijuana, like they need to be educated. Hey, this stuff is going to show positive for that. There's a lot of false positives and negatives, but again, have a good idea of what shows up on those. Random tangent there. As I mentioned, a high abuse potential. You want to be really careful with using these drugs, especially if they have any history of substance abuse. They tend to be more prone to abuse with these drugs as well. And then what sort of withdrawal effects would you expect to see from an amphetamine? Because we said when you're withdrawing off of benzodiazepine, you get really agitated, you get, you're sweaty, you're anxious. What could happen with the withdrawal from the stimulant? Kind of opposite effect. Yeah, you expect them to be kind of lethargic, and they just kind of they don't have a whole lot of energy. So again, how can you deal with that? Taper over a long period of time, so say a couple weeks or so, try to taper down on their dose. That can help them mitigate a lot of that, because a lot of patients may not be on this year round, especially kids. They may be on it throughout the school year, and then say during the summertime they're at home, they don't really need to worry about doing their homework and stuff. They can maybe come off of it for a few months and go back onto it. Sometimes it's good to have that drug holiday to kind of reset things a little bit for those patients there. Otherwise they're on it for all 10 years of school or whatever, how many years you're in primary education, that's a lot of drug burden on the patient over time. So something to consider there. And then, there is some concern for growth stunting. Maybe some of it comes from the appetite suppression, things like that. It is a concern, but of course it's weighing the risk versus the benefits, right? So as long as they're keeping up with their milestones and they're doing okay on the medication, it's probably not going to be a big deal. But as I mentioned, the drug-free holidays is kind of good from time to time. So other non-stimulant drugs that you can utilize for ADHD include things like atomoxetine or Strattera. This is actually a non-controlled substance here, and it works as a selective norepinephrine reuptake inhibitor. So it's kind of like working like something like duloxetine would be as an SNRI, but this one is not used for depression, simply just used for ADHD. Good for adults. Does have a slower onset of action. As soon as you take an amphetamine, those levels of amphetamines are climbing in the bloodstream. They work pretty well within an hour or two. This is going to take several weeks, just like we saw with some of our antidepressants that work through reuptake blockades. So something to consider there. No abuse potential with this, which is nice. So that means it's a schedule. There's no schedule on it, right? So it's not a controlled substance, which is good. You can write a whole year-long prescription for that for the patient. That's going to be no problem for them. Adverse effects wise, you're going to see some GI disturbances. I do see some people end up losing some weight off of this, and I think a lot of that's due to that norepinephrine sort of effect there. Hepatic injury is a possibility here. We're going to watch for that. And then just like with our antidepressants, they all had a black box warning for suicidal ideation, right? Same thing can happen with this one, okay? It just tends to be a class effect for these SNRIs. Yes, sir?
I don't know if you just mentioned or not, I'm a little lazy after lunch, but
it's okay.
It's an SNRI. Why isn't it lumped in with the other SNRIs? What makes it unique?
For whatever reason, I guess they just said, hey, we got this drug, and they, trialed it out and said, hey, it tends to work for ADHD, let's just market it for that. Yeah, so this may be a good option if you had a patient that can concomitant ADHD and depression. May this be a good option for them. I don't know if they maybe tried it in trials for depression. It didn't really work all that well. Who can say? I haven't really dug into the history of the drug too much, but know that this is particularly what it's marketed for.
Is it like as common as the stimulants? I feel like I haven't really seen this.
Yeah, so I tend to find people who are not good candidates for stimulants will utilize this. I absolutely agree. You will not find it being used quite as often. I think now that adult ADHD is a little bit more commonly recognized, I think you see more adults who are on amphetamines nowadays. But before then, a lot of it was Strattera for a lot of those patients there. I haven't really seen any kids that have been on Strattera before. It's really all just the amphetamines for them. But if I had a patient who had a history of hypertension, I'd be more prone to put them on this than I would on a strict amphetamine, right? Especially if they get their blood pressure under control first, and then this would probably be a better option for them.
Just like a personal thing, I have ADHD, but they started me on Strattera because I was 9, and his reasoning kind of was, we want to start you on this first before we go to the stimulants, just to see if you can actually respond to this, and I didn't, so then I went to stimulants.
Yeah.
And also I've seen some people, like my friends in college that have gone to try to get ADHD medication, they try to give you this first because they don't want to offer you the amphetamine.
Yeah, absolutely. So again, it's probably pretty practitioner dependent, I would imagine. Whereas let's start you on something a little bit, a little bit weaker, not weaker necessarily, but something that's a little less, speed-based, I guess, so start you off with something a little bit lighter, see if you respond to that, and if not, then you can bump them up to the stimulants. You're absolutely right, because there's been some really interesting news stories out there about patients who had been on it all throughout high school, and then they graduate, they're not really going to college anymore, so their doc doesn't want to give them a script for it anymore, but they're absolutely physically dependent on that drug, and so unless they get weaned off of it appropriately, they're kind of addicted, and they'll go through a lot of means in order to get that drug back because their body is so used to having that around. Some sad cases are out there because of that. One anecdotal story I will supply is I would recommend not taking these stimulants unless you have a very good reason to. I had one friend in college who we had an anatomy final one day. It was the anatomy lab. You guys ever had to do the anatomy lab where you dissect a cat? And so there's basically a room full of dead cats, and it's like this nightmare room, but you had to go through and pick out all the different, anatomical structures and all that sort of stuff. And so it was an 8 o'clock lab, so we had to get up early. My friend, who was was relatively drug naive to the stimulants, he decided one night he was hanging out with a girl, as you do in college, and then realized, oh, I still got to study for this test. Oh my gosh, it's like 2 o'clock in the morning. I'm just going to pull an all-nighter. I'm sure none of you have ever done that because you're all very responsible, got a lot of sleep before all of your tests. So he had someone that gave him like a half of an Adderall, just a half dose. And when he came to me that morning to pick me up on the way to the lab, I'd never seen anyone who was so just flight of thoughts. There was so much verbal diarrhea coming out of him that he just couldn't keep a thought straight in his head, right? So because he'd never done it before, and he needed to have his mental faculties about him to be able to identify, is it this muscle or this muscle in the cat? He just couldn't even focus at all. He was so distracted with all that norepinephrine, all that dopamine and everything, that he ended up failing the test. I had to retake the entire final, or I had to take the lab because of that. So again, don't do drugs is what I would recommend unless prescribed by a practitioner, right? So anyway, yeah, don't do drugs. They're not good. Some other things you could do, right? So instead of just purely giving stimulants here, you can do an alpha-2 agonist. So this is very similar to what we saw for hypertension. Well, if the patient's too overstimulated, what if I tried to just depress the system a little bit? And so this is where I can use something like guanfacine or clonidine. I more often see guanfacine being used. There's an extended release preparation that there is out there now called Intuniv. These patients will be on. And again, by preventing that catecholamine release, it's thought to kind of decrease overall activity within the CNS and hopefully help the patient to kind of focus a little bit better. These tend to be less effective overall than your stimulants are going to be. And in fact, some patients I'll end up seeing they'll be on stimulants, they'll get that in the morning time, and then to bring them back down so they can actually go to sleep and get a good night's rest, they might be put on guanfacine overnight. Again, it's not a good idea to kind of be mixing, matching your uppers and your downers and all that, but for some patients it tends to work out, and that's kind of the best cocktail for them. But just be aware sedation is going to be something seen commonly with these that do get tolerant to that over time. Hypotension, constipation are other kind of common things you see with that. Okay. Again, therapy is going to have to be really personalized depending on the patient and the practitioner and kind of what they've seen work for them before. And then the dosage form is dependent on a lot of factors. So, do you want to use an extended release preparation? Do you want to use immediate release, patches, liquid preparations? All of it needs to be really kind of determined based on the patient's comorbid conditions, adherence, etc. And generally, stimulants are going to be pretty much your first line. If you want to, you can try using something like atomoxetine or Strattera as a first line potentially. And then obviously antidepressant therapy could also be used here as well as good combination therapy. You can kind of look at all facets of their mental health and see kind of what things you need to focus on. Is the reason why they're not being able to focus very well because they have untreated depression or anxiety? Well, then deal with that as well, and that can kind of help to clear up some of your problems, right? All right. So any questions on that? If not, let's move into the neurology section. Talking about neurology and headache disorders. It's something you guys probably all experience right about this time of day when I start talking, right? Anyway, let's talk about epilepsy first. Have you guys covered this yet with Professor Kaplan? All right, so we're going to focus mainly on the drugs. I'm not going to go into each and every single type of different seizure you're going to find here. A lot of the drugs we're going to be dealing with typically have a wide range of activity. They can treat many different types of seizures. There'll be a few exceptions to that, which I'll make special note of, and I'll make note of it quite a bit, so because it's something you want to know, probably for like maybe testing purposes potentially. But what is a seizure? Yeah, abnormal firing within the CNS. Usually too much firing is going on here. And again, epilepsy is kind of the general term for people who have these seizure disorders here. What happens if you have many seizures in an order, in a row? You never get back to your baseline mental status. It's called status epilepticus, right? So again, if you have multiple seizures and the patient does never get back to their kind of baseline mental status, that's called status epilepticus. And again, that's a medical emergency. We see that quite a bit in the emergency department. What do you call it when a patient is in that kind of that post-seizure sort of mental status? So they're kind of foggy, they may not be completely with it. Post-ictal, right? So again, the post-ictal sort of time frame. That's important to consider because a lot of the drugs we're going to be giving are working by slowing down the CNS, and they can actually cause you to look a little post-ictal in and of themselves, right? Because again, they're going to have CNS depressant effects here. So again, it's important to be able to distinguish between those two. Anyway, think about the etiology of why they're having a seizure in the first place. So for instance, febrile seizures oftentimes get treated much differently than a seizure may be caused by a medication, right? So again, if I have a medication-induced seizure, what should I do for that patient? Probably stop the medication, right? There's actually quite a few different medications that can do this. I'm not going to give you the entire mnemonic for it. They actually have one called Otis Campbell. It's quite a long mnemonic, which I'm not going to get totally into, but you have to think about things like that because whenever we have patients who are presenting with a new history of seizures, especially like an adult, it's very odd they would develop seizures in the adult time frame unless there's some other sort of preceding thing that caused it, right? It could be drug exposure, it could be head injury, it could be a lot of things. We want to try to key in on that. So one of the things to note here as well, there are things like, alcohol. What do you think alcohol, is that normally a CNS stimulant or depressant? Typically depressant. So why would I put alcohol on a cause of seizures here? Withdrawal, absolutely, right? So you can have alcohol-induced seizures from the withdrawal, alcohol withdrawal-induced seizures. Anyone know what the general term is for like very severe alcohol withdrawal? Delirium tremens. Also, actually, ironically, a very good beer as well, if you ever see that in Publix. Yeah, it's called delirium tremens, and oftentimes can be manifested as seizures seen in those patients because, again, they're very used to having that CNS depressant effect around. When you lose that, you're going to end up finding this hyperexcitability there. Things like phenothiazine antipsychotics. You're going to see seizures associated with that, especially in overdose. Antidepressants, bupropion, TCAs, toxic levels of our anti-epileptic drugs. That's what AED stands for. Which doesn't make sense, right? Why would I give a drug that can cause seizures? Well, just like our antiarrhythmics, any of those can cause an arrhythmia, even though they treat arrhythmias. Same thing here. At high enough levels, a lot of these anti-epileptics can actually cause seizures for those patients. So, and also look at non-compliance with anti-epileptic drugs. A lot of times, the first thing we'll ask when patients come in with a seizure, especially if they have a history of it, they're on medication, I say, well, when was the last time they took their doses? A lot of times we get kids who are traveling in from either out of the country or they're traveling in from out of state because they're here maybe on a Make-A-Wish trip or they're here going to Disney or whatever the case may be. They get thrown off their normal schedule and parents are like, oh no, I forgot their Keppra at home. Okay, well that's why the kid's having a seizure, right? So in those cases, they forgot their dose. How am I going to treat that? Give them a dose of the drug, right? So again, instead of having to reinvent the wheel, a lot of times you can get them caught back up on their normal schedule and then they're right as rain. So these are things to consider. Okay, so basically the pathophys here, what we're finding is there's an abnormal repeated firing of these neurons that will then spread and typically produce one of these seizures here. What you're going to find is that we're going to go back to our action potential here, look at all the different ion channels and how they're opening and closing and all of that. But what you're going to find is that typically there's going to be an imbalance here between our GABA activity and then more of our excitatory effects from our glutamate activity. Remember, GABA is going to be the brakes on the system, glutamate is kind of the gas pedal there. And again, if I have too little GABA, too much glutamate activity, that's what ends up leading to a seizure in those cases there. And in fact, the way that we're going to actually treat those seizures is by, in some cases, increasing the GABA effect. That's where things like our benzos are going to be coming into play a role here. Okay. So looking at this, again, how do we maintain the normal resting membrane potential for these neurons? Sodium potassium pump, just like in the heart, right? Remember, sodium potassium pump is going to help maintain that normal electronegativity in there because it's going to be pumping sodium against the concentration gradient out of the cell, bring potassium in, right? You guys can't get away from that pump. It's going to come back to haunt you for the rest of your careers, I guarantee you. Now, what you may find is that depending on the case, depending on what's going on with the patient, they can have altered activity of this pump. Maybe the pH of the blood has now changed to a point where maybe the pump is not working as efficiently as it would. This helps to lower that seizure threshold, right? So when you lower that threshold, it means it's easier to have a seizure. For something that raises that threshold, make it more difficult to have a seizure there. And so, and again, also like we saw with the heart, remember there was a refractory period. What was that refractory period? There's an absolute and relative refractory period. And what did that mean, though? You couldn't have another signal come along and trigger off another action potential. Same thing happens here with the neurons. However, if there's any kind of dysregulation with that sodium potassium pump or anything that's not working effectively, you may find that that refractory period is shortened in which case another action potential could come along and fire it off, right? So this is an abnormal sort of firing of these neurons, and a lot of times it goes back to that refractory period and how it's being either shortened or elongated, as the case may be. So looking at these patients, how you're going to be making your diagnosis, obviously history is going to be one of the biggest things. You know, if you have a patient who had a history of, you know, doing a whole bunch of amphetamines coming in, causing a seizure, okay, that makes pretty good sense there. But look for other things like, you know, bacterial infections. Look for other things. So, you know, things like labs can be very useful. A lot of the electrolyte imbalances can lead to seizures. Like hyponatremia is a pretty common one. You know, seeing especially during the summertime, you have patients who will go to like these like summertime boot camps, and they'll go out and they'll be in the hot Florida sun, and they'll get super dehydrated and just drink a ton of water and not get any salt in, and all of a sudden they come in for seizures, right? Because their sodium is now like 115 or something. You know, so you know, do the workup, figure out what the heck's going on here. Look at the medications, look at the labs. It's going to be able to help you out. MRIs, EEGs also can be very useful here, but I'm not going to get super deep on that. Now, as I mentioned, toxin-induced seizures, there's a lot of drugs that can cause seizures, so just be you know, willing to look it up. If you have someone who has an unexplained seizure, look at the medication list. Look to see if any of these could be potentially playing a role here. Again, this is not all inclusive. This is just some of the common things that we will run through as toxicologists, trying to figure out, okay, what the heck's going on with our patients, you know? So for instance, when you're looking at something like methylxanthines, anyone know what I'm referring to when I say methylxanthines? Talked about them before during the COPD and asthma talk. We talked about theophylline, and most of you are probably consuming a methylxanthine right now, or have at least today at some point. Caffeine. Caffeine's another big one, right? Caffeine can induce seizures in some cases because of its stimulant properties, right? So again, you have to keep a wide differential when you see a patient with unexplained seizure, and substances could be playing a role here in a lot of these cases. Anyway, so our goals for these patients is obviously, one, like to have no seizures if possible. We'd also like to mitigate the side effects. A lot of times it's difficult for these patients when you give them antiepileptic medication. The question is like, well, how effective is it really being, right? Because again, sometimes it can be pretty variable when a patient has one of these seizures. So I put them on medication and I'm like, okay, well, they haven't had a seizure for 3 months. Is it because they wouldn't have had a seizure anyway? Or is it because the medication is actually working? So sometimes it's hard to discern what's going on there, but they certainly will develop side effects from the medications while they're on it. So that can become an important discussion where you say, okay, well, let's try maybe tapering off the medications and see how it goes. But this is something we're going to be focusing on is the side effects here. Obviously, increase quality of life, address their concerns. However, just keep in mind, not everyone's going to be able to achieve these goals here, right? There are some patients you'll have them on 4 or 5 different antiepileptic medications, and they will still have seizure activity. A lot of times, it could just be getting the goal down to maybe only having 2 or 3 seizures a day versus having, say, 12 or 15, right? These are oftentimes a lot of these kids with like mitochondrial deficiencies or some sort of genetic disorder that leads them to have a lot of seizures, and they're very difficult to manage. Now, things to consider when you're putting a patient on an antiepileptic, you want to look at things like the kinetics of the drugs here themselves, and they can vary pretty widely based on how old the patient is. So, for instance, with phenytoin, which we're going to talk about as kind of a old school standard sort of antiepileptic, the dosing here changes pretty drastically. So, what do you notice here? Younger patients require a bigger dose. Why would that be? Well, no, because it's all milligrams per kilogram, so you're taking the weight out of the equation there, right? The metabolism is a heck of a lot faster based on their enzyme expression for the younger kids, right? As they get older, you're going to find that that's going to go down, metabolism goes down, and you have to readjust the dose. So not only is their weight going up, you have to adjust for it, but also the metabolism is going down. If you don't adjust for that, you end up leading to super therapeutic levels. They can develop toxicity from that, right? This is where you got to be cognizant of that. Look at their other medical conditions, their ability to comply with the medical regimen, right? So again, they need to be adherent. If they're not going to be, it's going to be very difficult for them to control those seizures. And then also look at things like insurance coverage. You know, a lot of these patients may have pretty extensive medical bills in addition to their antiepileptics, so you got to make sure to find something that's going to work for them from a cost standpoint, right? So steps in therapy, for one, did a seizure actually occur? It's always a question, right? But someone who presents with a seizure, they are always having a seizure, right? No, sometimes they have what we call pseudo seizures. They're not really seizures, but they want to come in, they want to get maybe some Ativan or something. So we had one trick that we would use to figure out if someone was actually, we had patients who would kind of fake being comatose. And so we did this thing where you do the arm test, so they're laying back on the stretcher, and you lift their arm over their head, and you let go. And normally if a person is not conscious, what would happen at that point? Their hand would hit their face. If someone was faking, what would happen? They pull it away. It's one way you can figure out they're fibbing or not, right? So anyway, so figure out if it's an actual seizure or not, right? Because you don't want to treat someone who didn't actually have a seizure. You need to figure out if they're malingering or something else is going on, right? But let's assume our patients are being honest with us. Let's assume they actually did have a seizure. What type of seizure was it, right? So there's different types of seizures that can manifest. Was it absence? Was it grand mal? What type of seizure are we dealing with here, right? And then is the pharmacotherapy even indicated? We have a lot of infants that will come in with febrile seizures. But that's an issue where you got to get their temperature down. It's not actually a seizure disorder where you treat it with antiepileptics. You treat it with what's a good antipyretic we can use? Acetaminophen. We give them some Tylenol. That fixes it, right? Acetaminophen is not an antiepileptic drug, but we use it for febrile seizures because it helps bring their temperature back down, right? So these are things to consider, right? And then, the question is, do you always start with the first seizure? Difficult to tell. Generally, though, if they have 2 or more unprovoked seizures, that's when you're going to definitely consider doing more kind of long-term maintenance therapy for these patients. And the question is, what drug is going to be most appropriate? This oftentimes comes down to, one, what the type of seizure was, and then also what is the patient really going to tolerate? And we're going to find there's a lot of different options that are out there, and a lot of it is based off what side effects they actually are able to live with and which side effects are going to be manifesting, as we'll see. And then the monitoring is going to be really important here. Do we need to monitor specific drug levels? Do we need to monitor liver functions? What do we need to monitor for here? And we'll talk about those when we get into the individual drugs. So, antiepileptic drugs, again, none of these are disease modifying. So if someone has an ongoing seizure disorder and you take away the drug, guess what? Seizures are going to come back, right? So that's understandable. A lot of patients tend to be controlled just on monotherapy, but many of them end up having to be on several medications, at least 2 or more, and about 10% of those patients, about 20% of them still remain uncontrolled, meaning they're still having some breakthrough seizure activity from time to time. There's some other things you can do, things like vagal nerve stimulators. There's surgery potentially. You can actually take out, if you have an actual foci within the brain that's triggering off a lot of the seizures, sometimes you can actually go and take that out potentially. That way they can give the doc a piece of their mind. Okay, anyway, and there's even things like ketogenic diets. Anyone know what that is? Maybe some people experimenting with ketogenic diets. It's a very high fat, high protein, low carbohydrate, actually no carbohydrate diet, as few carbohydrates as possible to put them into a state of ketosis. What does ketosis do for, I think, a seizure patient? Not necessarily. It's more of an issue of pH. Yes, sir. It's going to increase the threshold to have a seizure because you're putting the body into a state of ketosis, which is going to decrease the pH, right? So you're going to induce a little bit of a metabolic acidosis, and by bringing that pH down, you make it more difficult for those neurons to have that abnormal firing, okay? And so that can be very difficult because guess what? Especially with kids we're dealing with, a lot of the medications come in what dosage form? Come in liquids. Well, how do we make things more palatable for kids in liquid dosage forms? Put sugar in it, right? So again, you can't really put that sugar in there anymore. So we got to figure out ways to get around that. And so if you ever see someone who says they have a dextrose allergy on the chart, chances are they're probably on a ketogenic diet. That's how we denote that and make sure we're really cognizant of the fact that they need to make sure we keep all carbs out of any of their sources we can. Let whatever carbs they do get, let the dietitians figure that out. But we need to make sure our drugs don't have unintentional carbohydrates there. But anyway, just another thing that you can potentially try. So, as I mentioned, to determine optimal seizure therapy, we're looking for things like adverse reactions that are manifesting, drug interactions, the mechanism for the drugs themselves. Especially when you're looking at combining multiple drugs together, typically do you want to have drugs that have the same mechanism or maybe different mechanisms? Usually different, right? Because you can get better synergy out of that rather than trying to go through 2 drugs with the same route there. And again, cost, compliance, all going to be big things to look for too. So, as I mentioned, monotherapy should be good for most patients that are out there, and they still don't achieve good control. That's where you can add on an additional medication there. Once they fail kind of multiple therapies, that's when they start to go with some of these other routes, like maybe surgery, ketogenic diets, etc. Usually when we see a kid who's on a ketogenic diet, they're usually already on 3 or 4 antiepileptic medications already, and that's kind of been the next last resort they've been gone to at that point. Okay, generally, you want to start low and titrate up slowly because a lot of these are going to have some CNS depressant effects. They're going to cause, sedation, ataxia, decreased ability to focus, especially when they're in school and things like that. So you want to titrate up, and how long that takes can be really dependent on the patient, see how they're going to be tolerating it. Basically, you're going to be watching the patient's response. Now, just because they didn't have any seizures during that period doesn't mean they would have had seizures without the drugs. So that's something you have to at least monitor for. And a lot of times some of these drugs are going to be utilized in therapeutic drug monitoring, so we can actually look at levels to give us an idea of whether or not they're in that therapeutic range. And so oftentimes the drugs get changed over based off of either lack of efficacy, they're still having seizures, or due to side effects and drug interactions that pop up here. As I mentioned, consider if you're switching to try using a medication with a different mechanism, because sometimes they'll have some better results with that. So going through a chart, if you imagine going through kind of a stepwise approach here, it makes pretty good sense here. So you're looking at starting off with an antiepileptic medication, is the seizure, are they under control, right? Are they still having seizures or not? Whether or not they're having side effects, right? That's going to be the next thing you're considering. Okay, well, maybe the drug's working really well for them. They haven't had a seizure in 6 months, but man, these side effects are just not really working for them. Their LFTs are going through the roof, or they can't concentrate in school anymore, or whatever the case may be. That's where you need to consider. Okay, well, do we need to go to a different drug altogether? Do we maybe need to adjust the dose? These are kind of the stepwise approaches you're going to be looking for. Again, combining drugs if they're still not seizure-free, even with the single monotherapy, but be very careful with your drug interactions. Just like we talked about with like VPA, valproic acid, and lamotrigine, putting those together, like you have to be really careful with those drug interactions, and we'll talk about that in more detail in just a few moments. Okay, so the main groups we're going to be focusing on, we have one are sodium channel blockers. We're going to have some calcium current inhibitors. So some that have some calcium channel blocking activity, but these are not the normal calcium channel blockers we're thinking about. We have some things that are going to enhance GABA activity. We're going to have some glutamate blockers, and then there's some other ancillary ones which we're not going to get too much into, but we have things like carbonic anhydrase inhibitors. Now, if you remember, where did we talk about carbonic anhydrase inhibitors before? It's a diuretic. Anyone remember what drug fell into that category? Acetazolamide. Good. So what did that do in the kidneys? So block carbonic anhydrase. So block in the proximal convoluted tubule, it blocked reabsorption of bicarb, right? Because it couldn't convert it back into CO2 and water, right? So you end up peeing out a bunch of bicarb. What does that do to the pH of the body? Goes down, makes it more acidic. What do we say about the ketogenic diet? Makes the body more acidic. It increases that seizure threshold, right? So again, there's some other ways we can try managing this, but the main ones we're going to be talking here about here are going to be these main 4 categories, right? Carbonic anhydrase inhibitors not used frequently, hormones not used frequently. There's also going to be some new ones that we'll kind of mention briefly. They're out there that we just really don't know how they work. We just know that they have some efficacy, but we may not know the full mechanism. Okay, so getting into it, sodium channel blockers. Why do you think these work? Sodium channels are important for the phase 0 depolarization, right? So again, if you're looking at a typical neuron having an action potential, here's the resting membrane potential, right? This phase 0 is caused by sodium channel influx. So if I can block that, if I can slow that down, it's going to make it more difficult to have that action potential. It's going to slow down the firing there, and it's going to slow everything down globally to the point where hopefully that really excitatory sort of signal gets interrupted and stops. Okay, so that's the main way that the sodium channel blockers are going to be working here. Now, again, one of the things we saw is that this can also affect things like the heart as well, right? So we're going to be aware that there could be some cardiac issues to pop up from this as well, because again, sodium channels are really important for the heart's action potentials. Okay, you guys remember all of that. Don't worry too much about the different states here, but we'll look at different places where the different sodium channel blockers are going to work. And just keep in mind, some of the drugs are going to have kind of multiple mechanisms, so we'll make note of that as it comes up. So looking here, imagine the sodium channel being open allows sodium to flow in along the concentration gradient. A lot of these are going to be working at the channel to keep it in the inactivated state. So that way you kind of prevent further sodium from influxing in. This is where things like carbamazepine, phenytoin, topiramate, lamotrigine, and valproic acid and zonisamide are all going to be working. Again, if you notice a drug is listed here that I don't talk about specifically on a slide, you don't need to know it, at least for our purposes here, but I'll probably talk about most of them. And again, we've already talked about some of them. We talked about bipolar disorder, right? So now we're going to get a little more detail about them. As far as the calcium channel goes, we know there's several different types of calcium channels. They're out there. We know that when we're dealing with like calcium channel blockers from a cardiovascular standpoint, those are usually L-type calcium channels. Here, you'll find that antiepileptics are actually working on the T-type calcium channels here. And so, and one of the unique places we're going to see this works is going to be for those absence seizures. And we know what an absence seizure is? I see a lot of them happen throughout the classroom, all the time. I snap out of it when I make a joke or something. Right, so I see a lot of absence seizures in this group here. You probably all could benefit from some ethosuximide because it's a calcium channel antagonist of that T-type calcium channel and tends to work pretty well for those type of seizures. Valproic acid probably does a little bit of this activity too, but again, by blocking that calcium influx, and calcium is normally going to be stimulatory during those action potentials, by blocking calcium influx and slow down that action potential. As far as GABA goes, we have 2 main types of GABA receptors. We have GABA A and GABA B. GABA B is going to be more important when we talk about muscle relaxants a little bit later on in the course. GABA A is the main one we're going to talk about here. We've already talked about the drugs that work on GABA A already. Anyone remember? What, 2 days ago? Or yesterday, I guess it was? The benzodiazepines, right? Our benzos are going to be the main things that are helping to make GABA work better, right? They're going to help facilitate GABA binding to that receptor and allow what to flow into the cell? Chloride, right? So again, in most cases, we saw we were blocking positive ions from getting into the cell. Now we're trying to allow for negative ions to flow into the cell, okay? Chloride is going to make the potential more, to make it more negative. It's going to be hyperpolarized. It's going to be more difficult for that neuron to fire. So again, when you're talking about acute management of seizures, this is the main mechanism we're going to be shooting for. We're going to give them benzodiazepines to try to shut down those neurons from firing any further, okay? And so again, benzos are going to be the main thing that's be working here. As mentioned, GABA B are going to be more linked to potassium channels, but we're going to focus on those when we talk about muscle relaxants later on, probably like I think in the ortho section. Okay, so looking at the GABA neurons, there's other ways you could affect it as well. So certainly with benzos, they help for the GABA that's there to bind more readily, to work more effectively. But there's other things we could do additionally. So for instance, we could try to modulate the activity of an enzyme called glutamic acid decarboxylase, and that actually can increase the amount of GABA that's available to be released. So if I can try to increase the amount of GABA available, more of it's there to interact with the receptors. That's one way to do it. Or potentially I could do something like block the reuptake of GABA. So if I could block the reuptake, I have more GABA out in the synaptic cleft, and that can then interact with those receptors. That's another way that could be potentially working. So something like tiagabine can actually work through that mechanism there. And actually, there's certain substances you can actually ingest. So when I say glutamic acid decarboxylase, you see that glutamic acid. What's another name for glutamic acid? Glutamate, right? We said glutamate's a very excitatory neurotransmitter. So there's a delicate interplay between glutamate and GABA. Glutamate turns into GABA. There's actually some cases where you can actually have that conversion being inhibited. That's usually when people have a pyridoxine deficiency. It's kind of a tangent, but I was just going to mention it here just because it's a good opportunity. But there's actually certain substances that can do that. So there's actually a certain type of mushrooms. If you were to actually go out foraging for mushrooms, which again I don't recommend doing unless you're an expert mycologist. There's actually an old saying, there's old mushroom hunters and there's bold mushroom hunters, but there's never any bold old mushroom hunters. They usually get the wrong kind and they die. But it's actually interesting because it's actually chemically structurally related to actually like rocket fuel. It's called hydrazines based rocket fuel, and actually can deplete B6, this pyridoxine, and actually end up leading to this excess of glutamate, and you have these intractable seizures. So if you ever see someone with status epilepticus getting a big dose of B6, usually that's what we're giving it for, is to try to replete that pyridoxine and giving them able to make their own GABA again. Anyway, a little bit of tangent there, but anyway, so again, several ways we can make GABA work a little bit better, either by blocking reuptake, maybe producing more GABA, or just enhancing it and making it bind better. That's going to be the main thing we're focused on. Okay, so the GABA neurons, I mentioned another way we could do this is by preventing the breakdown of it. So if I could decrease the activity of GABA transaminase, there's one called vigabatrin that actually does that. That can help to increase the level of GABA that's available. And as I mentioned, enhancing the GABA to work better with the receptor. That's where our benzos and also a drug called phenobarbital or barbiturates are going to be working. You guys have heard of the barbiturates before? Say phenobarbital, pentobarbital, that's what I'm talking about there. Those are very old drugs. So here we have the GABAergic neuron. It's going to be releasing GABA from these vesicles. So I could either help the GABA to bind better with the benzos or the barbiturates, right? Or I could do things like blocking the reuptake, or I could block the metabolism thereof. Lots of ways to affect GABA. But this is going to be the main way we're focused on, is where the benzos and the barbiturates are actually working. Okay. Looking at the glutamate receptors, well, we said glutamate's pretty excitatory. What if I block the activity of glutamate? Well, that would have a anti-seizure sort of activity as well. So there's a few drugs that actually work on blocking that. There's a lot of different glutamate receptors that are out there. The main one I'll focus on is going to be the NMDA receptor. If I heard of that before, maybe if you ever look at things like the drug ketamine, how that interacts with glutamate, it actually has some NMDA antagonism there. But there's a few drugs that will be working on it through this mechanism as well to decrease the activity of glutamate there. Again, don't worry about these other ones. We're not really going to focus too much on those, but the NMDA is an important one since we're in methyl D-aspartate. And so looking at something like felbamate, levetiracetam, this is actually going to be a really important one. This is starting to be one that I see used more and more frequently as a first line go-to sort of anti-seizure medication. So we'll talk about this at length a little bit later on. But just know that there's different receptors out there. Some drugs may have some activity, but this NMDA is going to be the big one we're focused on. Okay, not too worried about this stuff. Just be aware that some of these can actually help to facilitate things like binding of the NMDA receptor a little better, but for our purposes, just don't focus too much on this. Just know there's a lot of different activity at the different glutamate receptors. As I mentioned, things like progesterone, estrogen, these all can be playing a role, either preventing or actually causing seizure activity. So in some cases, patients with seizure disorders, if you were to start them on an oral contraceptive, could actually be either potentially worsen their seizure disorder or actually make it a little bit better, depending on the case there. But therapeutically, we don't really use these as anti-seizure medications. And then just real briefly, I mentioned acetazolamide could be potentially used as a carbonic anhydrase inhibitor, but we're not going to focus on that too much in depth here. All right, so any questions so far? I heard some mumblings about thresholds and higher thresholds and lower thresholds and hyperexcitability and all that stuff. So just to draw it out real quick, because I know you guys like my artwork quite a bit here. So again, imagine that here's your resting membrane potential. Actually, it's probably not a good line to put it. Imagine this is your resting membrane potential, and here's the threshold. This is where you actually have the actual action potential occur here, right? So again, this is where the actual action potential is happening, right? So if I were to give something that would make the cell more negative, to hyperpolarize it, I'm going to then have my potential now being down here, okay? Now the difference between here to here is now bigger, thus I have a larger threshold I have to clear in order to have that action potential. As opposed to here, this is a smaller threshold, which I forget the laser pointer. Right, so this has increased the threshold to have the action potential, even though it's more negative. Does that make sense? When I say something decreases the seizure threshold like an antipsychotic does, you would find that this delta here, this difference, is going to be smaller. So it's easier to have that action potential, easier to have that seizure happen there. Okay, so just for clarification's sake. Anywho, getting into the anti-epileptic drugs themselves, we're going to find that there's a lot that are out there. There's over 20 available. I'm not going to cover all of them in great depth here. I'll cover the main ones you run into most frequently. And there's always new ones being coming out, and quite been a few recent ones nowadays. Some of them have mechanisms we have no idea how they even work. We just know that they tend to have some activity here. What's been another recent addition to our armamentarium for treating epilepsy? Maybe a natural substance. Marijuana, absolutely. So we'll talk about marijuana real briefly and its utilization for treatment of seizures. More specifically, which component of marijuana? CBD. Actually, CBD is going to be the main one that has the anti-seizure activities. We'll talk about that briefly in just a little bit here. Did I turn my mic on? Nope, I did not turn the mic on. You guys supposed to let me know. So anyway, what you're going to find is that not all of the new ones have been studied necessarily as single agent therapies. So some of them have been using it more as an add-on. So you'll get a feel for it after a while. Kind of see like, okay, well, this one's typically used as an add-on as opposed to just monotherapy. I'll kind of point some of those things out as we go forward here. Generally, though, they all work relatively well amongst one another. Some patients are just going to respond to ones versus others. Some patients you're going to find some are intolerable due to side effects, even though they may work very well for their seizures. So that's all going to be depending on several things. And again, it's hard to do head-to-head trials amongst these between the different drugs here, because again, there's so many different types of seizures, so many different medications. We may never have a good, clear answer to say yes, this one is absolutely more effective than all the other ones. A lot of it's going to be more anecdotal and just seeing how the patient responds to it. So phenytoin, or Dilantin, is the first one we're going to talk about here. This one is going to be a pure sodium channel blocker, right? So blocking sodium channels, preventing the action potential from occurring. Very good. This one tends to be pretty difficult to manage due to several features here. One of which is going to be the fact that it's highly protein bound. It's about 90% protein bound. And we mentioned the protein bound portion is active or inactive? Inactive, right? But what could potentially cause that the free fraction to actually go up? If you have a drug interaction, something else comes and kicks off the protein is one thing. What if I had less protein to bind to it? Albumin is the thing it binds to. What if I had hypoalbuminemia? That's going to be leading to some pretty drastic effects on that free fraction as well. So we'll mention that in just a few seconds. The other thing is that it is metabolized by CYP2C9 and 2C19. If you remember back to when we talked about warfarin, those are important enzymes for warfarin metabolism as well. So you have to be careful with drug interactions there. And not only that, but also phenytoin can induce CYP3A4 and 2C family of enzymes. So it makes it very complicated from a drug interaction sort of standpoint when you're going to be monkeying around with levels pretty significantly there, mainly to reduce levels by inducing those enzymes there, right? This is going to be pretty wide ranging as far as activity goes. It's going to work on a wide variety of different types of seizures. Not really absent seizures. We'll talk about the one drug that's specifically used for that a little bit later on, but generally most other types of seizures, phenytoin is going to be a good drug for it. So things you're going to expect to see with the majority of these seizure medications is going to be overall mental slowing. You're going to see lethargy, ataxia, yeah, especially depending on the level. As levels go up, you're going to find that it tends to have much more significant CNS depression there. Other things you may find, it's kind of unique to phenytoin itself, is things like hirsutism that can happen here. Gingival hyperplasia is another pretty common adverse drug effect. They have good oral hygiene that helps to kind of mitigate that to a large degree. Other things include things like vitamin D deficiencies, non-stimulation. So again, you want to make sure you're supplementing that, especially if you're dealing with like little kids or older individuals, maybe at risk for osteoporosis, things like that. And for a long time, this is good for kind of first-line general management of seizures. Nowadays, because of the difficulty in dosing and drug interactions, kind of taking a little bit of a backseat, but you still may see it being used in a lot of cases, especially like in ER settings and things like that, as we'll see in a little bit. Also, there's also some skin manifestations that can happen here, including Stevens-Johnson's. I'll kind of give some summary slides later on that talks about all the different antiepileptics can cause LT levels increasing. They can cause Stevens-Johnson's, etc. So I'll show you some summary slides later on there. So one of the things we'll mention is this thing called Michaelis-Menten kinetics. Basically what this means is that the kinetics get a little funky with phenytoin depending on the level here. Now if you guys remember back to pharmacodynamics, what's the difference between first order and zero order kinetics? Zero order was basically looking at this straight line here where it's the same amount of drug per unit of time gets metabolized. So even if the drug level is very high, it doesn't get metabolized any faster than if the level is very low, right? First order kinetics is what? It's the same percentage of drug being metabolized every single hour or whatever time frame you're looking at. So the higher the drug level is, the more drug gets metabolized, right? And majority of drugs follow which type of metabolism? First order, yeah, majority of drugs follow first order. What phenytoin does is that you drive the levels up too high, you actually oversaturate those enzymes in the liver and you switch over between first order and you flip over to zero order. What do you think that does to the half-life of phenytoin? It increases it quite dramatically, in fact, to the point where the patient is not able to get rid of that drug very easily because they're undergoing the zero order kinetics here. So I'll give you a good example of how this comes up clinically. We had a patient who presented to the ER. They were on phenytoin at home, but they maybe run out of their doses or they forgot to take it or something like that, but they presented with seizures. So what do? She was on phenytoin before. Let's go ahead and load her up with phenytoin. So we give her a dose of phenytoin. Seizures haven't come back. She's looking good, but shift change comes around. Shift change normally happens about what time of day? 7 to 7, right? So shift change was happening here. This is in the morning time, and for whatever reason, there was not good handoff between the nurses, between the overnight nurses and the day nurses, as sometimes happens. So there was an order, and this is back when we saw paper charts. There's an order for phenytoin. The nurse overnight did not document that it had been given, so the nurse who was coming on that morning said, oh, look, there's an order here for phenytoin. Let me go ahead and give this dose of phenytoin. So what happens to the patient? They get 2 doses of phenytoin. Get 2 loading doses of phenytoin. So now the level is way too high, and they switched over to the zero order kinetics. All of a sudden, the patient's complaining of feels like the room is spinning. She's getting very nauseous. She can't even stand up on her own strength anymore. She's about to fall over because of this overdose of phenytoin that we had administered as an iatrogenic overdose there. And basically what had happened was the level got very high. She flipped over to the zero order kinetics, and at the rate she was metabolizing, she was going to be in that hospital. You know, she'd come in for something that she could have been discharged from the ER for. Now she's getting admitted. It was going to be there for at least a week to work off those levels, unless we did something to intervene to get rid of it a little bit quicker. But you got to be very careful with this stuff, especially with phenytoin, because if you drive the level too high, then you're going to run into this issue of the half-life getting very, very long very quickly. Okay. Typically, this is usually started off by giving it as a loading dose, usually if the patient is presenting with a seizure for the first time, and then you're giving it as PO doses afterwards, so kind of more long-term maintenance therapy. Again, don't worry about the dosing specifically here, but just give you an idea of kind of what normal numbers you're going to be seeing for this. The thing I will note here is that the therapeutic range is, we've got 2 different types of levels here. We have a total level and a free level. What do you think the difference between these 2 are? Yeah, one shows us all the phenytoin in the blood. One only shows us what's not protein bound. So what do you think the utility is of doing a free level? Yeah, so if, say for instance, the patient has a total level that comes back and it says, oh, it's 15. I think 15, that's in the therapeutic range. That's totally fine. That's no problem, right? But the patient's still experiencing ataxia. They still feel really dizzy. You know, what's going on? Well, what you can do at that point is actually get a free level and see what that is. Say the free level comes back and it's 2.5. that obviously tells you something's going on to where there's too much of the drug that's free. Maybe the albumin's low, maybe there's a drug interaction kicking the phenytoin off of the protein, but that free level is going to give you a good idea of what the heck is actually there physically able to act with or interact with those sodium channels in the brain. So again, then you might ask, well, why don't we just always get free levels? It's a little bit more expensive, and some places you may not have access to it. It might be a send-out lab where you actually have to send it to somewhere else in maybe a day or so before you actually get the levels back. So there's reasons why we don't always do it. But again, if anytime you get a phenytoin level and it just doesn't make sense, check a free level, because I guarantee that's going to tell you something better about what's actually physiologically active at those sodium channels. Okay. And I already mentioned the half-life thing. As dose increases, the half-life is going to increase as well when you flip over to zero-order kinetics. That's because the protein binding is going to be so high here, about 90% or so. So again, normal therapeutic level, say 10 to 20. That's why the free level therapeutic is usually 1 to 2, because that's that 10% that's physiologically active, right? But if you have renal failure, if you have critical care patients, these are all patients who tend to have higher free fractions, either due to hypoalbuminemia or something else. They tend to be more prone to some of these side effects here. Other things to consider is that phenytoin can be a pretty strong vesicant. You guys remember what vesicants are? Yeah, if they extravasate outside of and they get to the subdermal tissue, they're going to cause a lot of damage here. So this is what we call purple glove syndrome you see with phenytoin, and that's definitely a lawsuit waiting to happen there, right? So basically, whenever we're giving phenytoin, you want to make sure it's in the very as deep a vein as possible. You got to really make sure the access is good, because otherwise you can end up running into that. The reason for that is because phenytoin is really difficult to get into solution. So how do we get it into solution? Well, we try to do things like increasing the pH to like 10 to 11. One way to do it, but that can be irritating to the skin. We also have to mix it with a lot of things like propylene glycol and alcohol and all those other things that tend to be very irritating to the skin. So that's why you end up seeing those issues there. The way you get around that is actually by giving a drug called Fosphenytoin. Basically, it's phenytoin with a phosphate group added onto it. That makes it much more water soluble. The body then converts it over to normal phenytoin, and it's able to work just as well. So typically, if you're given an IV, we like to use fosphenytoin whenever possible because it's much less painful. You can give it intramuscularly potentially, a lot less phlebitis that can develop from this. Other things you want to consider as well is if you give phenytoin too quickly. As I mentioned, the sodium channels in the brain are affected certainly, but where else do we have the sodium channels we care about? On the heart, right? So you can see things like bradycardia, you can see things like hypotension related to that, so you can't give it too fast. So fosphenytoin helps to get around a lot of those problems there. But there's some cases where you'll have drug shortages. We had the problem where fosphenytoin, there's an issue with the glass vial. It had shavings of glass that were actually getting into the solution, so they had to recall on it, and then we had no more fosphenytoin. So now we had to switch back over and actually using regular phenytoin. So again, sometimes those things can dictate what drugs you have available to use for your patients. All right, moving on, we have carbamazepine or Tegretol. We already mentioned this as being used for bipolar disorder. So again, looking at this, you already know a lot about it. Again, remember, it can cause things like SIADH, which leads to hyponatremia. Remember that it is going to be inducing its own metabolism, that autoinduction, so you have to make sure you titrate up on its dose to deal with that. It's also going to be inducing a lot of CYP enzymes like 3A4, 2C9, 2C19. Again, you got to be watching your drug interactions here, because again, a lot of these are going to be mucking around with levels of a lot of other unrelated drugs there. And again, be aware of things like the bone marrow suppression that can happen here, hyponatremia as we already mentioned, and again, the CNS depressant effects are going to be pretty typical for any of these antiepileptics here. Just to give you an idea what the dosing looks like when you're working through that autoinduction, you have to basically keep increasing the dose here because those enzymes are going to be more plentiful, so they're going to be more available to interact with that drug and metabolize it, so that's why you have to do that. And again, if I were to say add carbamazepine onto a patient who's already on phenytoin, you'd have to increase the level of phenytoin because again, it would auto-induce that metabolism of phenytoin. You'd end up seeing those levels would end up dropping, right? So again, these are things you have to watch for. And again, there's a therapeutic range for this one. There's another one we would do levels on. Usually 4 to 12 or so is typically a good therapeutic range there. Again, don't memorize the levels necessarily, but I may put a level on the test, and you have to be able to interpret what that means, right? Especially the phenytoin thing, with the free levels, like that may be something that require a little bit of thought on your part to actually process it and figure out what to do next with those levels. I mentioned oxcarbazepine is kind of a cousin of carbamazepine. There's no levels we can monitor for, but what was kind of the unique thing with carbamazepine, oxcarbazepine as compared to carbamazepine? Much more likely to cause SIADH. So the hyponatremia risk is going to be higher with oxcarbazepine than with regular carbamazepine. Okay. And then valproic acid, we also have already talked about. This one is going to have a little bit more wide-ranging activity. All that we've looked at so far has just been sodium channel blockers. Now we find that valproic acid has several different activities here, including blocking some of those calcium channels, those T-type calcium channels. And some people think it also helps enhance GABA a little bit, either increasing the availability or just increasing the actions of it. So that's why valproic acid has kind of a wide range of activity, because it has several different mechanisms there. And again, watch for things like, LFTs increasing. You got to monitor for that. Pancreatitis is another thing that can happen with valproic acid. Anyone remember the other lab abnormality you can find due to carnitine deficiency? Hyperammonemia. Yeah, so you got to watch for that too as well. As I mentioned, I had one patient who came in who was at school. They thought he was doing drugs at school. Really, he was just on valproic acid for bipolar disorder. They got a valproic acid level normal. The kid was completely loopy. Just couldn't even, had no idea where he was, what he was doing. Got the ammonia level and it was very, very high. So again, you got to keep in mind for that. You can have even normal levels of VPA and have very high levels of ammonia. And I put that picture up on the sticky board, so you can go back and look at that and why you end up getting the hyperammonemia there. But other things, this inhibits CYP2C9. So instead of inducing it, like a lot of the other ones we've already looked at, this one's actually going to inhibit it. And just keep in mind that the therapeutic range with a lot of these anti-epileptics can be a little bit soft, right? So soft in the idea that you can kind of push them a little higher than you would normally expect. And it just really depends on how the patient's tolerating it. So for instance here, some patients do really well at a level of 150 without really any side effects, and their seizures are well controlled. Just because it's outside of that normal range doesn't mean it's abnormal for them. It could be just right. So again, treat the patient, not the number, right? Good. This is very teratogenic. So if you had a pregnant patient who had a seizure disorder, or someone who wanted to become pregnant, you got to be really careful with this because it can definitely cause neural tube defects. So very teratogenic from that standpoint. Anyone know what young women of potentially childbearing potential should be taking to prevent neural tube defects? Folic acid, right? Can you start taking it once you're pregnant? Too late. You got to do it beforehand, right? Do it beforehand. Very important. Okay, so then moving on, we have our benzodiazepines. These are going to be good for the most part being used for acute seizure management, right? For acute seizure treatment. If I have a patient coming into the ER with an acute seizure, chances are they're going to get a benzodiazepine to help terminate that seizure. Some of them will be used for more kind of long-term therapy, but these are not great because, again, what's the big side effect with the benzos? A lot of sedation, right? So again, if I have a kid who's in school, they're going to have a hard time concentrating, their memory is going to be impaired. It's not great. It's like sending a kid to school drunk, right? Probably not a good idea, even though some don't like to do that themselves. Hopefully none of you guys like to do that, but not great. But sometimes, for these kids that have, they are, maybe other conditions are such that they're not going to school, but they have very severe seizures. Like oftentimes we'll have to give them chronically these benzos anyway, to just help control that. So there's some cases where you'll see that, and I'll mention those briefly here. Now, as far as things you want to think about when you're giving, say you have a patient with a new diagnosis for seizures, oftentimes you want to give them some sort of rescue medication, right? So something that's going to be able to treat that acute seizure when it happens. And traditionally what we've been giving them is something called Diastat or diazepam. And it's a rectal gel, okay? So again, is this something the patient is going to administer themselves? No, they're having an acute seizure. They're not going to be able to administer that themselves. So again, this is something for the parent or the healthcare provider, or not healthcare provider, but something, some other person taking care of that patient is going to be able to administer to them. And so patient education is really important because again, you need to train them on how to do this. Because again, if your kid all of a sudden was on the floor having a seizure, and you got to figure out how to get their pants off and use this drug and make sure it's at the right dose and all this kind of stuff, it'd be pretty harrowing, right? It'd be pretty difficult to figure that out. So again, education is super, super important. Make sure you're using the right kind of guides. A lot of the websites for these drugs will have patient education guides that will help you through it. Make sure you train them up on it before they actually have to do it, during the actual event, right? Nowadays, though, because it was pretty cumbersome to give rectal diazepam for these patients, because again, can you give anything orally to these patients when they're seizing? No, because again, their mouth's gonna be very tense stuff. They could choke on it, they could aspirate it, lots of problems with that. So that's why rectal administration was preferred there. However, nowadays, we're starting to move more towards using intranasal drug administration. So the thing we'll use for that, and a lot of our neurologists are doing this now, is using midazolam or Versed and giving that intranasally. Certainly can use the IV in the hospital setting, but we'll use it intranasally in the home setting. That way they'll just drop the dose. They'll have this little atomizing device will go on the end of the syringe, and they just stick it in their nares and administer the dose, and it actually works almost just as well, in some cases better than the rectal diazepam. And it's also a lot less cumbersome to give because again, you can get a lot easier access to the nose than you can to the rectum, right? So that's something you're going to see much more frequently, I think, as you go forward in time. Other things we can use pretty frequently for seizure management includes lorazepam or Ativan. This is probably the most common IV agent you're going to see used for seizure management. Just because it tends to last a little bit longer than Versed does and to prevent recurrent seizures from happening. And then other ones you're going to see used for more maybe chronic management with things like Klonopin, which is clonazepam, and then also clobazam or Ompi, which is a little bit of a newer one. But remember how they're working. They're helping to agonize, or they're binding to that benzodiazepine receptor site, making GABA bind more readily to the receptor, allowing for chloride to flow in more readily, right, and hyperpolarizing those neurons. And again, these are all controlled substances. So how long of a script could I write for these patients? 6 months at a time, right? C2s are the only ones that are of a limit of 90 days, but for anything 3 through 5, I could do 6 months, I could do 6 refills, I guess 1 plus 5 refills on those, okay? Now, as I mentioned, the kinetics for the benzodiazepines varies pretty widely depending on whether it's going to have active metabolites, whether it's more fat soluble, water soluble. Yes, sir?
I thought we said a year earlier. Is it 6 months or a year?
Just 6 months, right? So for a non-controlled substance, you get a year, if you remember. Yep, so non-controlled substances get a year at max. 3 through 5 get a max of 6 months, which you can write refills on. C2s, you cannot write refills, and the maximum amount you can write for is 90 days. However, with the new House bill, if you're writing for an acute pain indication, what's the max you can write for? How many days worth? Most times it's going to be 3, but they actually do up to 7 if you write for an exemption. But we'll talk about that in the next section when we get to the ortho pain management section. Kind of keep that in the back of your mind. But again, things are always changing, so you got to make sure you're keeping up with the laws here. So anyway, so again, some are going to be more fat soluble, water soluble. Again, just be familiar with the common ones that I mentioned here that we're going to be using for seizures. We talked about some of the ones that are better for older patients. Remember the lot benzodiazepines we mentioned are being better for older patients for anxiety and things like that because they're more water soluble. They don't have active metabolites. They're going to get cleared a little bit easier from those patients. And again, keep in mind these are going to be the go-to for acute seizures, whether it be the parenteral route, intranasal, IM, IV, whatever route you can get it into the patient. Other than oral is going to be good for them. And then, as I mentioned, for kind of long-term prevention of seizures, oral is probably going to be the most common route you're going to be administering it for them. Sedation, most common adverse drug reaction. And keep in mind, if they're on the drugs chronically, you need to withdraw off of it slowly. So again, if they're on Klonopin, so you're taking it 3 times a day, they've been on for the last 6 months, you have to withdraw from it slowly because otherwise what can happen? You get withdrawal seizures that can happen, right? Because again, their body's used to having that GABA effect around. If you withdraw that abruptly, their neurons have all those, they've downregulated those GABA receptors now because they're being chronically hit. They're going to be much more likely to have rebound seizures there. Okay, just like I said, alcohol withdrawal can induce seizures. Benzo withdrawal causes the same seizures. Okay. Up next, we have our barbiturates. This includes phenobarb. Is probably going to be the most common one. Anyone has ever had a pet with a seizure disorder, chances are they put them on phenobarb. Seems like the most common one that I've run into. Always like whenever I get like pet prescriptions, but I don't know it's a pet at the time. I remember getting this like order for Keflex one time. I was interning at a Publix pharmacy and got this like order for Keflex, and I was like, this probably like would kill a regular human if I gave him this much Keflex. And Keflex is pretty safe, and I figured out it was like for like a Burmese mountain dog or something like that. And I was like, oh, that makes much more sense. That's why his name was Rover. Interesting. Okay. Although you see some very weird kid names nowadays. I'm not going to divulge anything because of HIPAA, but you see some weird kid names nowadays. Just saying. Anywho, with phenobarb, these are going to be working to actually directly activate those GABA channels. So instead of the benzos actually helping to facilitate GABA to bind more readily, the barbiturates are actually going to actually open up those channels themselves. So you're going to find that typically these are much more sedating than a benzodiazepine might be, and you're also more likely to see things like respiratory depression, hypotension associated with these. So they don't get used quite as often. They're also very old school drugs. They've been around for a good long time, but nowadays we have a lot better drugs and maybe a little less sedating and still very effective for this. And in fact, one of the big cases we're going to use this most commonly, especially in peds, is for neonatal seizures. This is probably the most common drug we're going to go with for that patient population there. Again, not used too commonly because of all the adverse drug reactions, and it's also a controlled substance. Okay, so out of all the drugs we've talked about, at least for the neurology section, the only ones that have been controlled substances so far has been the the benzodiazepines and the barbiturates. So again, kind of keep note of those as we go through, because a lot of them are not controlled substances, and that's preferable because again, you can write for a whole year's worth potentially, right? It's better for the patient from that standpoint. Okay. As I mentioned, sedation, CNS depression, those common things you can see with this. In some cases, in kids, you can actually see that paradoxical reaction, similar to the benzodiazepines, as we mentioned before. So just be aware that they seem like they're kind of bouncing off the wall after getting it. It could be related to that. This one's going to be metabolized by CYP2C9, but will induce 2C9 and 3A4, so you kind of run into the same problem you run into with phenytoin and inducing those enzymes there. And so typically, we're going to be using this for patients who maybe have failed other anti-epileptic drugs, or they have refractory status epilepticus. This is usually like a third or fourth line drug. If we have a patient who's not really responding to anything else, we can put them basically into a medically induced coma with a barbiturates because of the profound CNS depression it can cause here. And again, the range is listed here. However, it can range pretty widely here. I've seen patients who have been kept stable on levels of 65, 70, not having any issues with it. So again, this is just more of a reference range. Again, it's just suggestive. It's not going to be absolutely set in stone. You have to be within this range here. Okay, another one called pentobarb. You may see this being used occasionally if you have a patient, say in the ER, is having refractory status epilepticus and they need to go into this pentobarb coma, as we call it. So very difficult to treat seizures. We'll sometimes get this. Again, not used very, very often, but if you ever see pentobarb in the ER setting in the ICU, this is typically what it's being used for. Anyone know what drugs we use for lethal injection? Potassium chloride. What else? Use a paralytic. What else? Something to knock them out. Yeah, so we actually end up using either pentobarb, we use sodium thiopental. So that way, and actually it's kind of interesting because the doses they're getting of the barbiturates is probably enough to kill them in and of itself. But we said we really want to make sure we're getting this guy or gal. They're a really bad person in life. Let's go ahead and make. I'm not advocating the death penalty or anything, but I'm just saying they're getting like some pretty hefty doses. They want to really make sure they kill off this person, right? So then they give a paralytic called pancuronium, and of course a paralytic is going to cause you to do what? Stop breathing, so that would kill them in and of itself. And then they finally finish it up by giving KCl, and that is what? Stops the heart dead in its track, right? So again, just a little bit of random trivia for you to try to lighten the mood a little bit, right? Here we just electrified them, I think, right? Old Sparky, Starkey. Anyway, a couple other drugs here. We have so those are kind of the go-to. You're going to find those being used very, very commonly. Some of the other ones here may get used with some rare occasion, include things like felbamate. This one's probably working through maybe some NMDA receptor antagonism, maybe through some GABA activity here. We're not really sure. We don't use this one too frequently, mainly due to the fact that there's a significant amount of hepatotoxicity and also the risk for this fatal aplastic anemia. So if you ever see that, it's probably in someone who's been failing a lot of other therapy, and this is kind of one of their last line that they're going to. So if you ever see that, pretty difficult to control patient, if I had to guess. Another one here called ethosuximide. This one's important because this is actually going to be working purely on those calcium channels and is the drug of choice for absent seizures. So if you had a patient with an absent seizure disorder, ethosuximide is the drug of choice for them. But otherwise, it's pretty well tolerated, but it doesn't really work for many other seizure types there, right? With like phenytoin, with phenobarb, benzos, they work for all kinds of different seizures. This one's really custom tailored towards absence. Next, we have gabapentin and pregabalin. So how do you think these drugs work? Work like GABA? Kinda, not really, sorta. They kind of look like GABA a little bit. That's kind of where they get the names from. They're structurally related, but they actually probably end up working more through calcium channels more than anything else. Maybe they kind of help to enhance GABA synthesis, but other than that, we don't really know why they're working so well. But these two are chemically related to one another. Gabapentin was the first one that came out. Pregabalin came out a little bit after that. Just keep in mind that these are good as an adjunct agent. You typically will not find patients who are on this by itself for seizure management, but it's a good add-on sort of drug here. It is renally eliminated, so if you have patients with renal dysfunction, you do need to adjust your dose, but the dose is pretty wide here. I've seen some patients being on as low as 300 milligrams of gabapentin a day. I've seen them being on as high as 3,600 milligrams of gabapentin a day, so there's a pretty wide range there that some people will tolerate. Now, for the most part, when you see patients who are on gabapentin or pregabalin, most often they're going to be on it for some sort of neuropathic pain condition, things like fibromyalgia, MS, lots of different reasons why patients might be on it, usually for neuropathic pain. So more often than not, that's where it's kind of gotten its main use there. Things like postherpetic neuralgia, things like that are really good for gabapentin and pregabalin to work here. What's interesting is that while gabapentin and pregabalin work identical to one another, gabapentin is a non-controlled substance. The pregabalin coming out afterwards, I guess there's enough patients that described euphoria during the clinical trials. They said, well, let's go ahead and make it a C5. So that actually is a controlled substance, even if it's kind of on the weaker end of things there. Next we have lamictal, or lamotrigine. We already mentioned this back in the bipolar section, but again, inhibiting sodium channels, probably inhibiting some glutamate release, working through some calcium channels, a lot of different things here. What was the big side effect that we mentioned you want to be educating patients to look for? This one was the rash and the Stevens-Johnson syndrome. You're really careful for. This is very much more common with lamotrigine than a lot of the other ones here, so you got to be really careful with that and make sure you're monitoring and let them know what to look for in regards to skin manifestations with that. Again, other than that, pretty well tolerated for the most part. But be careful because, again, if you mix this with valproic acid, you got to adjust the doses because otherwise the lamotrigine level is going to be too high, half-life is going to be too long, and they can develop that toxicity there. Just to give you an idea how you might want to adjust the doses here. Again, don't memorize this slide specifically, but just an example. Say, normally if I were to say start off on a patient with and they have an enzyme inducer on board and I'm adding on lamotrigine, you got to make sure you're actually bumping up your dose quite significantly. Versus if I have an enzyme inhibitor, say for instance valproic acid, then I actually have to go down on the dose quite significantly. Starting off on every other day dosing and then gradually titrating up to just say 100 milligrams given twice a day versus getting, say, 400 milligrams twice a day. So again, just show you how big of an effect those enzyme inducers inhibitors can actually have on the dosing there. Okay, next we have Keppra. This one is a kind of up-and-comer, getting a lot of use nowadays, at least for pediatrics. I can't really say quite as much from the adult side because it's been a few years since I've really done pure adults. But this one is actually working on a different sort of synaptic vesicle protein here, this SV2A. It actually is preventing neurotransmitter release. That's how we think Keppra is going to be working here. Really becoming first-line therapy for a lot of patients. The main reason is because it's so well tolerated. In fact, you can drive up some really high doses on these patients, and it's like water. They really don't have a whole lot of side effects from the drug, and it tends to be very effective for managing the seizures here. Other things that are nice is that it can be used as add-on therapy to other stuff without a significant amount of drug interactions. There's really not a whole lot of problems with this. The one thing you do want to be familiar with whenever giving Keppra for patients, especially children, they've actually found some incidents of things like increased aggression. Okay, if kids seem extra cranky when they're on this, it could be related to the Keppra they're actually administered. Don't really know why that is, but it tends to be something they saw in the clinical trials there. But nowadays, we're starting to see that, say for instance, a kid comes into the ER, say new onset seizures, maybe we get the seizure under control with say Ativan, but then having another seizure. Back in the day, we used to say, well, just go use Phenytoin next. Use Phenytoin as your next go-to. Nowadays, a lot of our neurologists think we'll just go to Keppra. So again, just goes to show you because of the lack of drug interactions, this is a really good drug to get the patients on, and then they can transfer over to oral and they can stay on that for the long term with no real big issues there. Next we have Topamax or topiramate. This one's kind of an oddball because it gets a lot of other uses for other things like migraine prevention, a lot of different things. But this one has kind of a wide range of activity, including antagonizing some glutamate channels, enhancing GABA activity. Just be aware of, you got to watch the renal elimination here. Do need to adjust your dose if they have pretty significant decreases in creatinine clearance. But the other interesting thing with topiramate is actually working as a carbonic anhydrase inhibitor to some degree. So again, you get a little bit of that activity where you're dropping that pH somewhat, and that can also help to increase that seizure threshold for your patient there. So that's another thing to know. Anyone know what else you could use this for potentially? Yeah, weight loss. Actually, you get a little bit of weight loss from this as well. So some people use it off-label for that. So topiramate, if you see someone on it, could be migraine prophylaxis, could be weight loss, could be seizure management. Just depends. Another new one I've seen used with some regularity. This is usually an add-on agent called lacosamide or Vimpat. This one's actually a C5 as well. So again, some abuse potential, but pretty minimal compared to some of these other drugs we've talked about. This one's nice because it also has an IV form available. So for instance, again, you don't have to memorize the dosage forms. They're available for all of these, but like Keppra is a really good one because it has IV and PO availability. This one does too. And again, pretty well tolerated, not a lot of side effects, very few drug interactions. And again, that's always going to be a preferable thing, especially compared to our old school stuff like phenytoin, carbamazepine, etc. Okay, so imagine you had a patient who had status epilepticus. How do you actually manage those patients? What do you do for them? For first thing, what do you want to do for any patient presenting to the ER? ABCs, right? So airway, breathing, circulation. A lot of times the patients end up intubated, especially if they have true status epilepticus, because again, they're not protecting their airway, and you start breathing for them. So that's something you're also going to be looking at. Think about this though. If anyone's familiar with intubation, what kind of medications are you giving them? Paralytic. So if they're paralyzed, can you tell if they're having a seizure? you can't, right? So it can be something that can actually confuse your exam a little bit because they could still be having a seizure. We call that non-convulsive status epilepticus. So you have to wait for the paralytic to wear off before you can actually see if they're developing a seizure again. You're also given the sedative as well, which you can actually have some anti-seizure activity. But anyway, so you want to make sure the airway circulation is going to be set first. Now, typically, the way you're going to be going is starting off with a benzodiazepine. Starting off with them like lorazepam, diazepam, midazolam, anything like that. One thing to consider if you're in the ER, patient comes rolling in, you want to ask EMS what question? What do they already get, right? So again, was diazepam given at home? Did they get any doses of anything from you? Because that way you already figure out, well, they've already gotten 3 doses of Ativan. They're still having seizures. Do I want to give them more Ativan? No, I'm probably going to go to something else at that point, right? So again, give you a good idea. And again, EMS are usually try to get in and out there as fast as they can. They probably have another call to go to. So get that information while they're there as soon as you can, right? If they're unresponsive, then we're going to switch over to something else, right? So they're still not responding to that, still having seizure. This is where we start to think about something like phenytoin or Fosphenytoin is going to actually be even more preferable. But there, this is IV we're giving here. And keep in mind that nowadays, at least for the pediatric side of things, we're starting to give a lot more Keppra. So levetiracetam is becoming much more common used over that. That's still not working. Use in something like phenobarb, like a barbiturate, something that's going to be even more heavy-duty CNS depressant is going to be used at that point. Again, this patient is probably already intubated here, but that's okay because all the CNS depressant we're giving is going to cause respiratory depression, but we're breathing for them anyway, so that point is not really going to be a big concern there. And then if they're still not working, that's when you're going to switch over to something like valproic acid, phenobarbital, maybe even pentobarbital. Again, hopefully most of these patients will not make it that far down the regimen. Usually 1 or 2 steps down the regimen is going to be all that's needed, maybe some benzos and maybe Fosphenytoin, Keppra. But again, you always want to have something else in your back pocket to move to next. And again, you're going to be consulting with your neurologist anyway to see what they need to be on. Right? Does that kind of make sense? Okay. If it doesn't, you'll let me know later, right? Fantastic. So do patients have to be on antiepileptic therapy forever? Some do. Some may not, though. You may find that if they're seizure-free for a period of, say, 2 to 5 years or so, then while they're on medications, you can try to titrate them down off of that. Obviously, they have recurrent seizures, then they have to go back up on their dose. But this is something where, again, you want to make sure they have good normal neurologic exam. There's no structural issues that are actually causing the seizures there. And make sure you're kind of withdrawing very slowly, especially from things like benzos, because you will see those withdrawal seizures being a risk there. Okay. Now, looking at drug levels, now again, always mention you want to treat the patient, not the number. So you have to make sure you're trying to interpret things very well. So why would I want to check a level? Lots of reasons, right? So one, I want to check to see for efficacy. So if I were to say, for instance, get a patient been seizure-free for a couple months, and I was just doing a routine check on the level, and I found it subtherapeutic, the patient's not going to have any seizures. Well, it could be because the patient just wasn't having any seizures, or maybe the drug was working at that low level. So that's something you may want to try to key in on and see what's going on there. Make sure before you get levels, you want to make sure you're at a steady state. How long does it take to get to steady state? 4 to 5 half-lives, right? So you don't want to check it too early because otherwise the level is going to be too low. And you may think you need to, say, go up in your dose potentially before you really need to. If you're checking for drug interactions, so for instance, if I was to add on something that may affect valproic acid level, I can throw on that new drug and then go and check the level of valproic acid to see what's going on there. And also, if they're having any kind of toxicity, adverse drug reactions, that's another really good reason to check levels for. So the common ones you're going to check levels for includes valproic acid, carbamazepine, phenytoin, phenobarb. Those are probably the most common ones. And actually, I have some docs will say, well, I want to get a Keppra level. And I say, okay, well, you want to get Keppra level, what's it going to tell you? Unless there's been a really good therapeutic range that's been set up for it to where they know that this level correlates to this much efficacy, doesn't really do a whole lot of good. But what are some reasons that I might want to get that level anyway? What if the level 0? They're probably not taking the drug, right? That could be a reason why they're having that seizures now. Because again, could the patient be lying to you and saying, yeah, of course I'm taking my drugs like I'm supposed to? Absolutely, right? So these are things you can try to check on. And again, if the level's too high and the patient's not having any problems with it and they're seizure free, guess what? Just don't do anything with it. You don't always have to adjust the dose just based off the level being outside of the range, okay? All right, so looking at the adverse reactions, kind of in summary, so looking at the CNS effects here. So in general, drowsiness, CNS depression, ataxia, these are all going to be very common with any of the antiepileptic drugs we're talking about here. Typically is worse with things like the benzos. The barbiturates tend to be a little bit more potent in causing that, but really any of them can do it. Beware though, this can lead to things like ataxia and falls. So again, fall risk is going to be a big deal, especially in your older patients there. We like lamotrigine and valproic acid tends to cause a little less sedation. Some of the other agents here, Keppra is probably on that list as well. As I mentioned, phenobarb is usually held off, especially in school-age kids, because again, it can help with, can cause some memory impairment there. Again, some of these other ones, can cause things like psychosis, anxiety, depression. So again, if they have any concomitant mental health issues, you want to go ahead and make sure you double check these meds, make sure they're not going to have any interactions there to maybe make that worse, or at least educate them, let them know what to look for as far as worsening symptoms, etc. Right? From a dermatologic standpoint, Stevens-Johnson syndrome is certainly a big concern. So here are some of the ones that can cause this, including carbamazepine, ethosuximide, phenytoin, phenobarbital. These are all thought to maybe have some kind of common intermediary metabolite that may be affecting this. But obviously lamotrigine is a really big one that I mentioned. Probably oxcarbazepine and lamotrigine, the most common ones we worry about as far as causing life-threatening rashes. Again, black box warning on Lamictal for that because of that. So you're going to be really careful of that. If there's any kind of sloughing, skin, blisters, rash, anything like that, let them know they probably need to discontinue therapy. Either come to see you or go to the ER, right? Hematologic side effects. Some of these are going to be causing things like agranulocytosis, aplastic anemia. So these are things you want to watch for. Things like check their CBC, looking for platelets, looking for neutrophil count, things like that. Carbamazepine, felbamate we mentioned probably won't be used too frequently, but valproic acid, phenytoin, those are good ones to check on that for. Again, what are some other things you can look for? Things like oral ulceration. You can look for things like fever, sore throat, unusual bleeding or bruising. Those could all be signs as well that there's a blood dyscrasia that's going on there, right? And then with the hepatologic effects, you can see here with hepatitis and liver failure being more common with things like carbamazepine, phenytoin, valproic acid. Valproic acid is probably the big one to kind of focus on that. You want to make sure you get baseline LFTs and then recheck it, usually say 6 weeks later, 3 months later, to see kind of where they're going from that standpoint. As far as monitoring goes, obviously, how many seizures are they having? Oftentimes they can either keep a diary or keep a calendar saying when they're actually having their seizures there. Look for adverse drug reactions, drug levels if necessary. Again, a lot of them don't have any levels necessarily that we can correlate to anything, especially Keppra being a common one. And then check their labs, right? So if I were to say, for instance, what labs to order with a patient on carbamazepine, you better include a CBC. You better include LFTs. You better include a sodium on there, right? These are things you want to look for. As I mentioned, therapeutic drug monitoring can be somewhat useful, especially for these four here. You don't have to memorize specifically that these are ones we're going to do levels for, or what the levels are, but just know that this is available. Make sure you use it appropriately, not just because you want to check a level. You need to have a pretty good clinical indication why you want to do it before you get one. And of course, a lot of the newer ones, we just don't have enough data to really correlate a level with the actual response that they're getting out of that. So that's why we don't really do normal routine monitoring for them. Okay, and then with the drug interactions, obviously this was huge, especially with a lot of the older agents. Many of them are CYP enzyme inducing, especially the 2C9 family, or the 2C family, I should say, 3A4, another big one, so you got to watch out for that. Again, please double check anytime you're messing around with anyone's antiepileptic meds for any of those drug interactions, because it could lead to some pretty big problems, either the levels being too low or too high, as the case may be. Other things to consider as well, it's kind of a special use case, oral contraceptives can be problematic because if you have a CYP enzyme inducer on board, like say phenytoin or carbamazepine, what you're going to find is that things like oral contraceptives, the estrogens tend to get metabolized too quickly, and that leads to decreased levels of estrogens, which could lead to accidental pregnancy. So imagine if I had someone who on valproic acid and I said that causes what? In a fetus. Neural tube defects, right? So again, you can start to see how some of these things kind of snowball one another. Oftentimes you want these patients on some sort of contraception, so what can I do to avoid that? Either I can intrauterine device, I can use an implantable one that bypasses first pass effect. I could switch them to a different medication potentially for the seizure management. A lot of options are there, but things you want to consider, okay? Like I said, you can use something like a medroxyprogesterone shot, like a depot shot, and it actually bypasses the liver effect. Also, it's actually just progestin. I don't have to worry about the estrogen component of that at all. But again, we'll talk about that more in depth on OB-GYN a little bit later on. So any questions on the epilepsy meds? All right, what do we got next? Parkinson's disease, that's quick. Just kidding, that's not quick. I'm going to go ahead and check the sticky boards. Anyone have any questions before I cut off the recording? Yes, ma'am. Yes. I would know that, yeah, for sure. So especially if I was saying, you know, you have someone on phenytoin, what would be a good drug to add on to phenytoin? If I said, you know, carbamazepine, that would not be a good combination because they're both sodium channel blockers. If I said like valproic acid, that would probably be a good combo. Things like that would be good to know. Okay. All right.